Ophthalmology. I hope all the speakers have their presentations ready so that we can save time. My name is Rashmin Gandhi. I'm here with Dr. Prachi Agashe.
I'll start.
No problem.
Are you Dr. Abhishek? Okay, this is. Oh, this is the list. Okay. Got it. Okay.
Is Dr. Koel Chakraborty here? All right. Your presentation is good. Swati is here. Manjushri is here.
Good evening, everyone. My topic for today is RNFL thickness analysis in bilateral optic neuritis, a cross-sectional study. There is no financial interest. RNFL is comprised of the unmyelinated axons of retinal ganglion cells. RNFL loss related to optic neuritis with or without multiple sclerosis has been poorly explored in our country. And bilateral optic neuritis is not only rare but also lacks proper correlation with RNFL thickness. Neuromyelitis optica is an inflammatory autoimmune disease of the central nervous system which has similar presentation like MS and is associated with a highly specific autoantibody against aquaporin 4. OCT is a non-invasive imaging technique which provides information on optic nerve head, RNFL thickness and macular volume, which correlate with axonal loss. My aims and objectives were to study the macular RNFL thickness in patients with past history of bilateral optic neuritis in comparison to age-gender matched controls, and to study the macular RNFL thickness in patients of positive serum anti-aquaporin 4 antibodies and to correlate final visual acuity with anti-aquaporin 4 antibody positivity. This was a prospective cross-sectional hospital-based study based at Regional Institute of Ophthalmology, Kolkata. The period of study was inclusion of cases and assessment of 6 months from October 2020 to March 2021, and the assessment continued for the next 3 months up to June 2021. The study population was 20 patients with established diagnosis of first episode of bilateral optic neuritis 2 to 3 months after resolution and fulfilling all the inclusion and exclusion criteria, and 20 healthy asymptomatic controls. The sampling method was complete enumeration, and the sample size was 20 eyes in each group. In the bilateral optic neuritis group, the eye with the thicker RNFL thickness was taken, and in the control group, the eye with the thinner RNFL thickness was taken. These are my study tools. The inclusion criteria were patients presenting with past history of first episode of bilateral optic neuritis with age more than 20 years, clear media and no other ocular pathology. The exclusion criteria were recurrent episodes of optic neuritis, other neurodegenerative diseases, diabetes, hypertension, glaucoma, tuberculosis, smoking, alcohol consumption and head injury. After proper history taking and clinical examination, we performed OCT examination, which was done by a single competent ophthalmologist, and 3 central subfoveal OCT images were taken, the mean of which was taken, and the subsequent segmentation was done by the machine, which revealed RNFL thickness, and the average values of the 3 per quadrant were calculated. These are some images. All the patients of bilateral optic neuritis and controls were further tested for serum anti-aquaporin 4 antibodies using ELISA test, and the results were tabulated. The statistical test done was t-test with a p-value of less than 0.05 considered statistically significant. This is a table of the age comparison between the 2 study and control groups, and there was no statistical significance found. In gender comparison of the cases and controls, no statistical significance was found, and the age comparison between anti-aquaporin 4 antibody positive and negative cases, no statistical significance was found. This is a table of the RNFL thickness in all quadrants around the macula in the study and the control groups, and statistical significance was found in all the quadrants including the fovea. And the RNFL thickness around the macula in anti-aquaporin 4 antibody positive and negative groups shows statistical significance in the central subfoveal region, inferior 3 mm quadrant, superior 6 mm quadrant, nasal 6 mm quadrant and inferior 6 mm quadrant. This is an ROC curve of the anti-aquaporin 4 antibody positive versus negative groups, and this gave us the coordinates of the curve. And the cutoff values from the curve were as follows. This is a table showing the visual outcome in the anti-aquaporin 4 antibody positive versus negative patients, and there was significant statistical difference. In the study population, 20% were males, 80% were females. The mean age of the study population was 38.20 years and the control population 37.90 years. Mean age of the anti-aquaporin 4 antibody positive cases was 38.31 years and the negative cases were 39.57 years. Thus, this was age and gender matched. The mean central subfoveal RNFL thickness was 9.80 in the study population and 12.30 micron in the control population. And the difference between the RNFL thickness was statistically significant. In the study population, mean CSF RNFL thickness in the anti-aquaporin 4 antibody positive cases was 7.77 micron, in the negative cases was 12.86 micron, and the difference was statistically significant. And the final mean visual outcome, and according to logMA scale, was 0.82 in anti-acoprin 4 antibody positive group and 0.18 in the anti-acoprin 4 negative group. Thus, the difference in the visual outcome was statistically significant. The inflammation and subsequent demyelination in optic neuritis causes thinning of the retinal nerve fiber layer due to loss of axons of ganglion cells, and this can be easily visualized and quantified by OCT. Most cases of acute demyelinating optic neuritis occurs in women between the age of 20 and 40 years, and we in our study found this to be true. Comparison of past literature, we can see that there was significant thinning of RNFL average thickness and temporal thickness in optic neuritis group compared to controls. And my present study showed RNFL thinning in patients of bilateral optic neuritis 2 to 3 months after resolution, which was in corroboration with the past study. In a study, we found that RNFL thickness in anti-acoprin 4 antibody positive cases was less than anti-acoprin 4 antibody negative cases, and this was also corroborated by past study. In a study, we found that the anti-acoprin 4 positive cases had poorer final visual outcome, which was also in corroboration with past literature. Thus, in conclusion, the mean central subfoveal RNFL thickness was lesser in the cases of bilateral optic neuritis group in comparison to control population. Among the cases of bilateral optic neuritis, central subfoveal RNFL thickness was lesser in the cases of anti-acoprin 4 antibody positive cases, and the final visual outcome was also poorer in the anti-acoprin 4 antibody positive cases. The limitations of our study was due to the low incidence of bilateral optic neuritis in our country and the ongoing COVID-19 pandemic. The number of cases included in the study population was low. That's why we had to do complete enumeration and no randomization could be done. We cannot consider the RNFL thickness of the control population as a normative database, and this being a cross-sectional study, there was no follow-up. These are my references. Thank you.
All right, Dr. Mukhopadhyay, that was a good idea and a good study. My question to you was that when you say bilateral optic neuritis,
Yes, sir.
so what was your diagnostic criteria?
The diagnosis criteria was on clinical examination, we could find the disc findings, and on MRI examination, we could find optic nerve optic nerve edema, and also the duration of visual loss, sudden painless visual loss, and thus in bilateral affecting group, bilateral eyes were
The
affected.
reason I asked you was because your average group, the age group is little, the patients that you enrolled are a little older than what we expect for a
Yes.
bilateral optic neuritis,
Yes,
number
sir.
one. Number two, okay, the patients in whom you found the positivity, you know that you're dealing with NMO. But
Yes.
the patients who you didn't find NMO antibodies,
Yes.
did you subclassify saying what would have caused optic neuritis? Because optic neuritis is an inflammation caused by different entities.
Yes, actually, we didn't rule out other infective causes or other like demyelinating disorder like multiple sclerosis. We didn't actually, that was not within the scope of study. It would have been better if we could have done this.
Did you suspect IIH in any of these patients?
Excuse me.
Did you suspect idiopathic intracranial hypertension in any of these patients?
Actually, most of these patients were obtained from the our department of neurology, and they referred the patients to us, having ruled out the other causes.
All right. We have been told that you are not a ratified member as yet. Is that
Okay.
right? Yeah. Anyway, but great work.
Thanks.
I would suggest that you probably would look at the subgroup of NMO because you know what you're dealing with, and probably analyze a little more.
Thank you, sir.
All right. Can we have Dr. Koel Chakraborty? Swati is here. Yeah.
Good evening, everyone. Today I'll be presenting the study on ganglion cell complex and retinal nerve fiber layer in perichiasmatic brain tumor patients, a prospective observational study. Myself, Dr. Koel Chakraborty, Chief and Presenting Author. The study was part of my thesis conducted under the guidance of Dr. Suchita Parijah and Dr. Bhagavat Nayak of AIIMS Bhubaneswar. There is no conflict of interest in this study and no funding was required. Anterior visual pathway lesions can lead to severe visual impairment, and diminution of vision is the commonest complaint seen in about 40% patients with this chiasmal syndrome. So there is a need for a sensitive parameter for its early detection. OCT can measure the ganglion cell complex thickness in these patients even those with normal or unreliable perimetry reports. GCC thinning can be detected despite normal nerve fiber layer and minimal field changes. The primary objective of my study was to find the mean RNFL and GCC thickness in perichiasmatic brain tumor patients. The secondary objective was to find the proportion of eyes with RNFL and GCC thinning before and after surgery, to find the association between GCC thickness and visual impairment, and to find the predictive factors of blindness. A prospective observational study was conducted on 37 patients with perichiasmatic brain tumor, radiologically proven, between the age group of 18 to 60 years with visual acuity, at least light perception in one eye, and those patients were operated between February 2019 and June 2020 in our institute. Patients with ocular comorbidities like dense cataract, corneal opacity, advanced glaucomatous optic atrophy, and other optic nerve pathologies were excluded from the study. A comprehensive neuro-ophthalmological workup was done at baseline with 6 months follow-up. Data was analyzed using STATA version 13. P-value less than 0.05 was considered statistically significant. So this is the OCT RNFL of a patient with pituitary microadenoma. This is the OCT GCC analysis of the same patient, and the visual field showing classic monoocular temporal hemianopia. So coming to the results, since 2 patients died in the course of illness, total 35 patients were taken for analysis, and objective assessment were done for total of 69 eyes. Coming to the age group, there was no statistically significant difference between the male and female category. Majority of the patients were from Odisha, belonging to the middle socioeconomic age group, and since 83% were female, so we got a statistically significant difference in the occupation category. Coming to the distribution of RNFL thickness at all visits, we saw that there was a decrease in the RNFL thickness in the superior, inferior, and nasal quadrant at the end of 6 months, and there was a slight increase in the temporal quadrant thickness. Coming to the distribution of GCC thickness, there was an improvement in the GCC thickness at the end of 6 months visit. So when the proportion of eyes with RNFL and GCC thinning were compared before and after surgery, we saw that there was an increase in the superior quadrant, in inferior nasal quadrant RNFL thickness, whereas there was a decrease in the temporal quadrant thickness, and there was a decrease in the proportion of eyes with GCC thinning. Statistically significant difference was seen only in the inferior and the temporal quadrant. Then we plotted the time trend analysis of the GCC thickness and mean visual acuity. As we already discussed, there was an increase in the mean GCC thickness as well as in the visual acuity, with a p-value statistically significant in the between the preoperative and the final postoperative visual acuity by the pair t-test. Then we compared the mean GCC thickness at baseline and at 6 months follow-up with the visual acuity, which was categorized into mild, moderate, and severe impairment and blind categories according to WHO classification. We saw that the minimum thickness was observed in the severe impairment category in both the preoperative and final postoperative visit. The reason may be because of a single observation which was seen in the 6 months follow-up and only 4 observations in the preoperative assessment. The GCC thickness between the different categories was statistically significant by Kruskal-Wallis test. Now the univariate logistic regression was performed using variables like age, duration of symptoms, preoperative mean RNFL thickness, preoperative mean GCC thickness, tumor volume, duration of surgery and surgical approach, and the crude odds ratio showed a statistically significant odds of having blindness in the thinned out RNFL in the superior, inferior temporal quadrant, and the preoperative GCC thickness in the preoperative visit, and only in the inferior quadrant and in the GCC thickness in the final postoperative visit. So there was a decrease in the mean RNFL thickness in the superior, inferior, and nasal quadrants after surgery. The mean GCC thickness and visual acuity improved after 6 months. GCC thickness was positively associated with degree of visual impairment, and the preoperative RNFL thickness in the inferior quadrant and preoperative GCC thickness predicted blindness at 6 months follow-up. So comparing with other studies, no single follow-up data was taken in the previous studies, no correlation was done. Only one eye of patients was taken, no OCT monitoring was done, and no correlation of visual acuity with GCC was done in previous studies. Limitations were difficulty in follow-up with high rate of morbidity in these patients and small sample size owing to COVID-19 pandemic. To conclude, OCT is a simple but indispensable tool that can diagnose, monitor, and prognosticate visual outcome in patients with perichiasmatic brain tumor. With proper counseling, guarded prognosis can be explained in patients with optic atrophy, and with timely intervention, vision can be restored in patients with the functioning ganglion cells. Thank you.
Thank you, Dr. Goyal. Nice study. So, when you say you can prognosticate in these patients preoperatively, what criteria would you use? I mean, if I have to do OCT in patients with brain tumor, and if I find, if I have OCT chart, what should I tell my patient?
So since the accrued odds ratio was statistically significant with the preoperative GCC thickness and the final postoperative visual outcome, we did a ROC analysis which I have not shown in this presentation, and a cutoff value was achieved. 92 micron thickness we had achieved.
So, you mean to say that if it is below 92, then patient is less likely to improve
Yeah,
vision
to
if the
gain
tumor is
vision,
removed? Is
yeah.
that what you mean?
Yeah.
Now that's little at odd with what was done. The pioneer study was done from Wills Eye Hospital in Philadelphia, and I think they found somewhere in
85.
70 or 80.
Yeah, 85 in the RNFL thickness, one study was done.
Yeah.
But GCC thickness,
90.
yeah, I have not found any other
Yeah.
study. 92 micron we had found in our case.
All right. Thank you.
Thank
Thank
you,
you.
sir.
Thank you so much.
Thank you, ma'am.
Swati?
Good afternoon, respected judges and the audience. Today I'll be presenting our research work on evaluation of OCT angiography changes in cases of NAION. My co-authors are Dr. Sumant Sharma, Dr. Rohan Chawla, Dr. Amar Pujari, and Dr. Rohit Saxena. We have no financial disclosure regarding the study. So as we all know, NAION is a common optic neuropathy above the age of 50 years and occurs as a result of decreased perfusion pressure in posterior ciliary artery, which leads to optic nerve head ischemia and thus edema. Modalities like fluorescein angiography and ICGA have been tried to delineate the microvascular plexus in these patients but have been unsuccessful. OCTA is a non-invasive modality which can delineate the microvascular plexus at different level. Multiple studies have shown that the peripapillary vascular loss on OCTA in NAI patient when compared to control-ized papillitis and papilledema. It may be interesting to explore the role of NAIN on the microvascular structure at the level of macula. Also, to understand the natural history of NAIN, the longitudinal changes have to be evaluated. So the aim of this particular study was to evaluate the longitudinal microvascular changes at disc and macula over a course of 6 months in patients of NAIN, where this was a prospective longitudinal study where we included 15 patients of NAIN who presented to us within 6 weeks of onset of symptoms and 15 age-matched control. All other causes of ocular pathology which may affect the retinal vasculature directly or indirectly were excluded from the study. All patients, after obtaining the informed consent, underwent detailed examination including contrast, color, fields, and OCTA. We used a swab source OCT by Topcon where we used 4.5 by 4.5 mm protocol for delineating the optic disc and macula at different level, at superficial level, at radial peripapillary level, at choriocapillary levels, and at macula at superficial capillary plexus, at deep capillary plexus, and choriocapillary plexus. So these are just images to show how vasculature looks at different levels, at the level of disc and at the level of macula. To quantitatively measure the vascular index, we use the ImageJ software, where we imported the OCTA image in the ImageJ software, converted it to an 8-bit image, then used an auto threshold program with minimum thresholding to delineate the major vessels. The same image was again reopened in a different window where we used local thresholding using Fancelker algorithm to delineate the microvasculature. So then we measured the number of pixels in the histogram for each of them separately. So to delineate the microvascular, we first took the total pixels, subtracted the major vessels from the total, and got the microvascular pixels. Then we divided it with the total pixels in the image to get the vascularity index. This was done at each level for each image at both disc and macula. To coming to the results, the mean time of presentation of symptoms was around 4 weeks, and almost 12 patients had some or the other systemic issues, and the visual acuity was very much severely affected. To compare it with the control, all the parameters at disc and macula at different levels showed significant reduction in the vascularity index as compared to the control eyes. The OCT parameters at the disc shows progressive decrease in all the indices except the choriocapillaries, which was more or less stable. So this was suggestive of a reduction in vascularity, likely due to the reduced metabolic demand due to the secondary atrophy of optic ganglion cells. At the macular level, all the parameters were kind of reduced, but they were more or less stable at the period of 3 months and also at the 6 months. When we correlated this with the visual function, we found that the visual acuity and the contrast sensitivity correlates positively with the vascular indices at the disc, but not at the macula. So to conclude, I would like to summarize, I would like to say that the peripapillary muscular densities at all levels, at the superficial, mid and choriocapillary levels, were decreased when compared to control group, which is similar to what was found by the various researchers. And this continuous decrease represents the reduced demand due to loss of RNFL. Superficial macular vasculature showed reduction at presentation, however remained stable, which is similar to that what has been reported by Fard and Tao et al. In their studies. These two researchers did not report any change in deep macular vasculature. However, in our study, just like Osterberger et al., we also found that the deep macular vasculature was affected, which may be suggestive of concurrent retinal ischemia secondary to the disc edema that causes vascular compression leading to further ischemia. Conclusion, OCT may be a useful tool to delineate the microvascular structure of retina and helps in understanding the natural history of NAIN. However, no study is without its limitation, and our study is limited by its small sample size, and I cannot rule out the segmental errors that may have occurred due to the presence of severe edema at the presentation. These are my references. Thank you.
Swati, what was the age group, mean age of all these patients that you...
Sir, around 55 years or so.
And did you do ESR in all these patients?
Yes,
CRT?
to rule out, yes. We included patients of NAN only when we rule out the arthritic causes and the inflammatory causes.
Because that will have a major bearing on what
Yes.
goes. And how did it compare? I know LVPI group had done a similar, they have published...
Yes, sir. From Dr. Gandhi et al., their group have published a similar study. They actually looked at the pattern of the vascularity index, at the loss of the vasculature, but did not calculate the vascularity index. So it was more of a qualitative analysis than a quantitative analysis, why we did a quantitative analysis.
All right, thank you.
Thank you.
One more question. Any difference in the group where you found that there was concurrent retinal ischemia along with the superficial vascular changes? Visual acuity wise, did they have any difference at 6 months?
Do you mean the visuals? Ma'am, the problem is that we had only 15 patients and only 1 or 2 patients showed some kind of improvement. So it was really difficult for us to compare the two groups. But yes, if we include more patients, in fact, that was one of the aim to find out from this study. But if we include more patients, maybe we'll be more enlightened about it. Thank you.
Thank you, Swati. Dr. Manjushri. Is Dr. Reena Rashid here? Dr. Reena Rashid? Dr. Shamika? Dr. Chaitra Arur?
Good afternoon, everyone. At the outset, I'd like to thank AIOS for selecting my free paper for presentation. I'd like to thank our chairman and moderator for this session. Today I'll be talking on the role of idebenone in the treatment of Leber's hereditary optic neuropathy. And I'm just going to start with a little background. So as we know, Leber's hereditary optic neuropathy causes progressive, irreversible vision loss. It causes bilateral visual field deficit, which over time is symmetrical. It is lifelong. It dramatically affects the impact of the quality of life. And most importantly, it affects young individuals. And these individuals remain legally blind. They are unable to find employment, and it hugely affects their psychosocial state as well. So having said all these things, in our Indian population, which is so vast, when we have so many young individuals who are going blind because of an inherited optic neuropathy, is there any hope? So there is hope. The hope is in the form of benzoquinone idebenone with this long chemical name. I've not put up the diagram, but let's find out more about the hope. So as we know, Leber's hereditary optic neuropathy is a mitochondrial inherited optic neuropathy which results from a point mutation in the mitochondria. There's selective destruction of the retinal ganglion cells, and the primary mutations are at ND1, ND4, and ND6, and these are the 3-point mutations, of which the G11778A is the most common. Idebenone is a short-chain benzoquinone. It's an antioxidant that stimulates the mitochondrial electron transport, and it results in reactivation of the retinal ganglion cells. So with this, the purpose of our study was to identify and describe the clinical features at presentation and the outcome of treatment with idebenone in only those genetically proven cases of Leber's hereditary optic neuropathy. So our methods included a study period from January 2016 to 2020, a 5-year period, in which 165 cases of suspected LHON were subjected to genetic testing, of which the genetically positive proven cases were 55, and these were those which had both primary as well as secondary mutations. Of these, 15 patients were treated with idebenone, and mainly because these were the patients who would adhere to treatment at least for some period and would come for follow-up and agreed to take the drug. And the drug was given in the dose of 900 milligrams per day in divided doses, and the clinical profile, investigations, mutations, treatment outcome was analyzed. So diving straight to the results, with the demographics, the mean age was 20 years. They were all males in our cohort. The time to diagnosis, that is the first hospital visit, and the genetically proven LHON diagnosis was about 9 months. The vision loss was sequential in 4 patients. It was simultaneous or reported to be simultaneous in 11 patients, of which 2 patients reported a more severe vision loss in the left as compared to the right eye. The idebenone which was used in 15 patients in a duration of 2 to 12 months, and this variability in duration is more because some were lost to follow-up and some just stopped the treatment after a couple of months. Additionally, some patients also received IV methylprednisolone, 8 of them, 2 received vitamin B12 injectable, and 10 received oral Neuro beyond Fort. The best corrected visual acuity ranged from 0.3 to 2.4 logmar in the right eye, and it was slightly worse in the left eye. In fact, in our cohort, it somehow showed that the left eye seemed to be more severely affected in LHON patients. The severe to profound vision loss pre-treatment was about 80%, 80 to 85%, and the post-treatment vision loss in the better eye remained severe to profound in 5 patients. Post-treatment with idebenone, there was an improvement in the visual acuity more than 2 lines, 5 in the right eye, 6 in the left eye, although bilateral more than 2 lines was 2 patients, and a 1-line improvement was also noted in a smaller number of patients. What's also interesting is that the patients with discordance, that is a difference in the vision, and here we define discordance as a difference in 2 line of vision between the right and the left eye. So there were 4 patients in our cohort who had a discordance in the vision, and in those 2 had bilateral improvement, whereas 2 had a unilateral improvement. Coming to the results in this, the pupils were, there was a RAPD in 5 and an ill-sustained pupil in 4. The optic disc findings are as shown. They were either hyperemic, optic disc edema, which were lesser in number because most of our patients presented slightly later, either with a temporal disc pallor or a diffuse disc pallor. It was bilateral in some, whereas some had a mixture of either temporal and a diffuse, one in each eye. And to the right, you can see the unilateral findings as well. Moving on to the imaging. So neuroimaging was performed in all, and hypersensitivities of the optic nerve were seen in 5 patients and a reduced caliber in 1, whereas it was normal in about 60%. The visual field showed a centrocecal loss in 6, but advanced field loss in 2 of the 8 patients who underwent testing, whereas a VEP was performed in 6, which was extinguished and reduced in most of them. Looking at I basically want to go to the genetic and the correlation analysis. In this, the genetic analysis, 12 patients had a 11778 mutation, 2 had a 14484, and secondary mutations were seen in 3. Looking at the results analysis as compared to age with vision improvement, the ones who improved were really all teenagers, less than 19 years or up to 19 years. Those who had vision improvement, additionally, 1 had vitamin B12 and 4 had IVMP, and the genetic mutation is as shown. Thank you. So this was the discussion on the 2 studies that have previously shown Idebinone. One is the RODOS as well as the retrospective study. And we also had some limitations which I've mentioned here, but we do have hope and there is light at the end of the tunnel. Thank you so much.
So did you do any tests before starting with the treatment?
Before starting?
Idebinone?
So they all were genetically proven patients. In addition, we also ruled out any other differentials as in, but this was done before the genetic testing, looking at the nutritional and the...
any liver function tests or renal function?
So they had a basic complete blood count done. They had a liver function test done. They did not have any kidney function tests done, but just the liver function and the complete blood count was done. And also the B12 and folate levels were looked at.
Did you start on day 1 at 900 or you gradually
No, we started, yes. So those patients who agreed were all started day 1, 900. So it was the 45 milligram tablets which are more commonly available, which costs about 10 to 15 rupees. Still, it's quite a bit for the patients. So some of them, as I mentioned, did stop in between and yes.
The improvement in visual acuity was documented how many months after taking
Yes, so that is a bit variable again. So it varies from a period of about 2 months to almost 12 months, but the maximum is the 12-month patient who has shown an improvement consistently and has followed up to 12 months.
Did the vision drop again or it was maintained?
So in one patient, the vision did not drop, but he mentioned something about a slight darkness which happened after stopping the drug. And then I've restarted him on the medication. So he's now actually just continuing beyond 12 months to, I guess, try and find an end point.
So would you now recommend Idebinone in everybody that you feel has LHON?
I would personally recommend in those who have a primary mutation. As yet, I wouldn't really recommend in a secondary mutation patient, yes.
All right, thank you.
Thank you so much.
Is Dr. Rehna Rashid here? Okay, may I have Dr. Shamika?
very good evening to all. I'll be presenting a study on the patterns of ganglion cell loss in compressive optic neuropathy and its utility in pre-perimetric neuropathy cases. This study was conducted in Sri Sathya Sai Institute of Biomedical Sciences, Bangalore. Ganglion cells are the second-order neurons that carry visual signals from the retina to the brain and are present in large numbers around the macula. Ganglion cells have their nuclei in the ganglion cell layer, while their axons travel all the way into the brain and synapse in the lateral geniculate body. Thus, space-occupying lesions anywhere in these areas can cause an atrophy of the ganglion cells, which can be studied non-invasively as a thinning of ganglion cells on OCT. Various studies have shown that the pattern of RNFL and GCL loss varies in different types of optic neuropathies. Lesions that compress the optic chiasma predominantly affect the nasal fibers that cross over at the chiasma, and hence bitemporal field effects and corresponding binasal ganglion cell loss is a characteristic feature of chiasmal compression. Visual field loss is an important indication for neurosurgery for tumors around the sella, and a feedback from ophthalmologists is an important consideration for neurosurgeons to plan surgery. Visual field testing is very subjective and is affected by various parameters. OCT, on the other hand, is objective and repeatable. The RNFL can show swelling due to papilledema and thinning due to atrophy. The GCL, however, is only affected by atrophy and is thus a better indicator for the permanent damage caused by compression. In this prospective cross-sectional case study, cases consisted of patients who were diagnosed to have a cellular or supracellular mass lesion on magnetic resonance imaging. Controls were age-matched healthy subjects. Cases underwent detailed hormonal workup and comprehensive eye evaluation. Cases that had adequate fixation and all the controls underwent automated perimetry and OCT measurements. A total of 66 eyes of 34 patients were included as cases, while 56 eyes of 28 healthy volunteers were controls. The mean age and sex distribution was similar in both the groups. Coming to the clinical profile, pituitary adenomas comprised the majority of our cases, followed by craniopharyngiomas and meningiomas. We included patients in various stages of treatment, such as those who were newly detected, recurrent, residual lesions, and those post-excision. Chiasmal indentation or thinning or compression was seen on MRI in 14 patients. Pituitary hormones were deranged in 24. Bitemporal field defects of varying depths and extent were the most commonly encountered field defects in the study. Some had advanced field defects involving 3 or 4 quadrants. 24 patients had normal visual fields in spite of having a space-occupying lesion at the in the cellular or supracellular lesion. 39 eyes had clinically detectable optic disc pallor. This diagram depicts the mean GCL thickness values in cases and controls in various quadrants centered at the fovea. There was a statistically significant difference in the GCL thickness between both the groups in all the quadrants except the outer temporal quadrant. Since there is a preferential loss of nasal fibers in compressive optic neuropathy, we went on to further study the nasal temporal asymmetry. We found that in the control group, the nasal ganglion cell thickness was higher than the temporal by a mean of 8.8 microns in the outer and 1.5 micron in the inner quadrants. Whereas in cases, due to the preferential nasal thinning, the temporal GCL was actually thicker than the nasal in both outer as well as inner quadrants. Thus, it is clear that there is a reversal of the normal nasal temporal thickness variation in cases of compressive optic neuropathy, and this was statistically significant both for the outer as well as inner quadrant values. Another important thing is that this finding is independent of a normative data because we are comparing the patient's own nasal and temporal and therefore can be applied without normative data. In order to study the role of ganglion cell thinning in pre-perimetric cases, we further performed a subgroup analysis in which we compared patients with cellular lesions on MRI but who had normal visual fields with those of controls. We again found a statistically significant reversal of the nasal and temporal pattern even in cases with normal visual fields. This shows that significant GCL thinning precedes visual field loss. To further understand how much of this nasal temporal difference can be called significant, we studied the ROC curve and found that the outer temporal and outer nasal quadrant difference was the most significant one. We found that if the nasal ganglion cell thickness is less than the temporal by 2.5 microns, it is suggestive of compression. However, due to the small sample size of our subgroup who had normal visual fields, the sensitivity and specificity of this finding is low, that is 75 and 85% respectively. This paves the way for larger studies in the future that can predict this difference with a better accuracy. Thus, to summarize, there is a significant thinning of GCL in compressive optic neuropathy. This reversal of nasal and temporal GCL thickness pattern is an early indicator of compressive optic neuropathy, and it precedes visual field defects. Further studies are needed to determine the significant amount of this thinning. GCL thinning can provide valuable objective information to neurosurgeons to determine the time of surgery. I would like to acknowledge the work of Dr. Kavita Rao and the departments of ophthalmology and neurosurgery at our hospital. Thank you.
So, all these tumors were chiasmal tumors?
So, cellular or supracellular tumors. Yeah.
Okay.
Thank you.
Dr. Chaitra? Dr. Rena Rashid? Is Dr. Ambasta Anita is here?
Good evening, everyone. I'll be presenting the variable manifestations in neuromyelitis optica spectrum disorder. Neuromyelitis optica spectrum disorder is an uncommon antibody-mediated recurring inflammation of the central nervous system. Longitudinally extensive transverse myelitis, bilateral optic neuritis, area postrema syndrome. These are the clinical presentations of the disease that often alert the clinician to the diagnosis. Approximately 75% of these patients present with antibodies to aquaporin 4, which is a water channel expressed at the foot processors of the astrocytes. More recently, a new antigenic target, myelin oligodendrocyte glycoprotein, has also been identified in these patients. So the diagnostic criteria revolves around the detection of aquaporin 4 antibodies, and also the presence of core clinical characteristics such as optic neuritis, acute myelitis, area postrema syndrome, acute brainstem syndrome, and so on. So this is a prospective study including 60 patients matching with the diagnostic criteria for NMOSD. The median age at presentation was 39 years. There's a female preponderance noted, and all the patients underwent a thorough clinical evaluation, blood investigations, neuroimaging, and lumbar puncture. So in our study, all patients presented with acute optic neuritis. 30% of the cases were bilateral. It was sequential in 40%. Recurrence was noted in 5% of our cases, and a posterior optic nerve involvement with the chiasmal involvement was seen in 15% of our patients. So bilateral simultaneous involvement of the optic nerves with a painful severe vision loss and a poor recovery are usually the clues to the diagnosis. Optic neuritis with transverse myelitis was seen in 5% of our patients, with brainstem syndrome in 3.3% and cranial nerve involvement in 1.67% of our patients. Longitudinally extending transverse myelitis is a specific presentation in this disease. Here the inflammation is in the central, the gray matter of the spinal cord, and usually extends over 3 or more contiguous vertebrae. Area postrema syndrome, it involves inflammation in the dorsal medulla. Here the patients usually presented with intractable nausea, vomiting, and hiccups due to the spread of the inflammation onto the rhomboid, the emetic reflex center in the rhomboid fossa in the fourth ventricle. In 3.3% of our patients, acute brainstem syndrome was noted, which usually overlaps with area postrema syndrome. However, these patients can present with oculomotor dysfunction or cranial nerve palsy depending upon the site of involvement. It is ideal to test all these patients with aquaporin 4 and MOG antibodies. In MOG antibody positive NMOSD, the predilection to the anterior optic nerve was noted, and the visual and motor outcome was better in patients with MOG positive antibodies in comparison to aquaporin 4 positive NMOSD. This is a FLAIR image of a patient showing multiple demyelinating lesions across brainstem, cerebellum, medial frontal temporal lobes, and the corpus callosum, mimicking multiple sclerosis. This can be differentiated from multiple sclerosis with the fact that the demyelinating lesion across corpus callosum is flatter here in comparison to multiple sclerosis, which may have finger-like projections termed as Dawson's fingers. So all our patients required high-dose steroids, as in 1 gram of IV methylprednisolone for 5 days, followed by a slow gradual taper of oral steroids over months. And they required long-term immunosuppression. Refractive cases required plasmapheresis. So to conclude, patients with optic neuritis need to be tested for aquaporin 4 and MOG antibodies when the onset of optic neuritis is bilateral, severe, recurrent, or has poor recovery, and if the neuroimaging is atypical for multiple sclerosis or has an extensive or a more posterior involvement of optic nerves, and also if there is a presence of coexisting autoimmune disease. Thank you.
Thank you.
Very nice analysis, Chetan. Dr. Ambasthanita.
Good afternoon, everyone. I'll be speaking on status of serum aquaporin 4 and MOG antibody in atypical optic neuritis in a tertiary eye hospital. So the ONTT trial showed good visual outcomes with patients with optic neuritis. However, the visual outcome in the Asian context was reported to be worse than the ONTT study. The reason being the large number of atypical optic neuritis which have been seen in Asia. So optic neuritis, according to presentation, can be typical or atypical optic neuritis. And in atypical optic neuritis, we can see sometimes the presence of biomarkers like the myelin oligodendrocyte glycoprotein or the MOG antibody and the anti-aquaporin 4 antibody, which is a specific serum marker for NMOSD. So aim was to know the status of aquaporin 4 antibody and MOG antibody in a cohort of atypical optic neuritis and analyze the clinical spectrum and visual outcomes in these cases. So there's limited literature on aquaporin and MOG optic neuritis, especially on MOG optic neuritis. So this was a retrospective observation analysis. Atypical optic neuritis patients or patients with either neurological symptom as first complaint or optic neuritis as first complaint were all included. Acute or chronic optic neuritis. Other optic neuropathies were excluded. So aquaporin 4 and MOG AB were detected by various means. Enterospecific examination, fundus, field, VP, neurological evaluation, imaging was done, complete hemogram autoimmune workup was done. And based on the seropositive status, patient's management was revised. Acute phase treatment with IVMP according to ONTT trial was given. Other modalities of treatment depending on the case was rituximab, plasma exchange, IVIG, or azathioprine. Now this is a representative case of NMO optic neuritis with bilateral disc edema, and following recurrent attack the disc became pale. And commonly seen features with NMOSD, that is posterior involvement of optic nerve, was seen, and long extensive transverse myelitis lesions in MRI spine, which is again a typical feature. This is a representative case of MOG optic neuritis where the final visual outcome was good, though the disc was pale. Patient was on azathioprine, and the commonly seen features of anterior part of optic nerve and sheath involvement was seen in both the eyes. Now this is not a representative case which we saw. The vision though was maintained. Azathioprine, the patient was on azathioprine, OCT RNFL showed thinning, but what we saw was an infrequently reported intracranial and chiasmal involvement in the MRI. Results showed we had 57 atypical optic neuritis patients, more number of MOG patients were seen, and a female preponderance was there. NMO and MOG positive patients both had optic neuritis as the first presentation, followed by transverse myelitis. There were common features of the optic neuritis in both the groups. Bilateral optic neuritis with recurrences and disc edema was a common feature. And pain was something which was more seen in MOG optic neuritis than in aquaporin 4 optic neuritis. MRI orbit showed significant optic nerve and sheath enhancement in MOG optic neuritis and none in NMO optic neuritis. And site of lesion was anterior optic nerve in NMO optic neuritis, but we also saw this in 2 patients in MOG optic neuritis. MRI spine showed long extensive transverse myelitis lesions more in NMO, but we also saw them in MOG patients. Visual outcome MOG optic neuritis was significantly better at the last follow-up, though in 3 patients out of 12 where there was neurological symptom as presentation, we had a final visual outcome of less than 6/60. In NMO optic neuritis, again, there was improvement in the visual outcome, though almost 50% of the patients had a final visual outcome of less than 6/60. MOG optic neuritis, as seen in literature, had a significantly better visual outcome than NMO optic neuritis. Now, this study by Piccolo shows more seropositivity for aquaporin 4 in the atypical optic neuritis cases, but we saw more of MOG optic neuritis in our patients. In another study, this is the Indian study, there was 20% seropositivity for aquaporin 4 in severe optic neuritis. This is something similar to our study. Literature shows that optic neuritis was the most common phenotype at onset, followed by transverse myelitis in both the groups. And long segment optic nerve lesions with intracranial optic nerve and chiasmal involvement was commoner in MOSD, while anterior lesions with perineuritis was commoner in MOG antibody disease. This is similar to what we saw in our study. But we also saw chiasmal involvement in MOG patients, and though not so much reported before, but there's a recent article in 2022 which says chiasmal involvement of MOG optic neuritis and aquaporin 4 optic neuritis occurs at more similar frequencies than previously reported. And so maybe we need more studies in this line. And the recovery of MOG antibody disease has been said to be good, with just 6 to 14% having residual visual acuity of 6/60 or less. And however, we saw in 3 patients out of 12 in MOG optic neuritis having a visual outcome of less than 6/60. In children, we had a MOG preponderance, and their age was less than what we saw in the NMO in the children. This has also been seen in literature. To conclude, presence of aquaporin 4 antibody or NMO antibody, pale disc, bilateral, recurrent optic neuritis, profound vision loss at presentation was associated with poor visual outcome. MOG optic neuritis, where optic neuritis was the first presenting symptom, had better visual outcome than those with neurological presentation, though the significance was less than 0.05. But again, we need to look more into this regard. Posterior optic nerve lesion was more common in aquaporin 4 optic neuritis and anterior in MOG optic neuritis, but posterior optic nerve lesion and chiasmal lesion were also seen in MOG. Aquaporin 4 optic neuritis patients were more likely to develop neurological symptoms on follow-up than MOG optic neuritis, and MOG positivity was more common in children. Understanding of MOG optic neuritis is still evolving, and we need more reports in literature. Duration of follow-up was not the same in all patients. This was a limitation, and more studies need to be done on larger cohorts. Thank you.
Nice, thank you very much. I think both of your, Chaitra and you actually addressed a very important point of optic neuritis and these circulating antibodies. Just wanted to ask both of you, during your analysis or study, did you find any temporal relation with the COVID or COVID vaccine, especially with MOG antibody?
Yeah, with MOG, just 2 patients I remember, they got recurrences. They already they were MOG positive patients, and then because we keep the phone numbers, they rang up and they had diminution of vision. Whether it was a reactivation or cannot really tell, or and there was one patient, but we couldn't really point out whether it was due to COVID because many of them were there without getting tested for COVID.
So did you find any temporal correlation of positive patients with COVID, either COVID infection or Covishield, especially Covishield vaccine?
You mean the vaccine?
Vaccine or, yeah. Because that's an interesting thought that has come up, that there has been some correlation, temporal correlation with COVID infection or what. I mean, again, as I said, I don't have firm data on it, but just a discussion and anecdote that maybe there is some relation with vaccination as well. I don't know whether you have seen any of these cases, or Manju, you have seen.
Yeah, we have seen.
So,
We have seen.
Manju, you have seen.
We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We have seen. We
especially MOG.
Especially MOG. Two of them have around 4-5 patients like that. Out of them, two have turned out to be MOG positive. One of them was LMO positive. And even post-vaccination, when we have patients, none of them turned out to be positive, but there are patients who are reporting post-vaccination also.
Optic neuritis, yeah.
It's difficult to say if it's causal or.
I know, but it's just that interesting thought that these somehow COVID seemed to trigger that antibody response, probably. I don't know. But nice, both of you, nice analysis. Thank you. Is Dr. Priyanka here?
A very good evening to all of you. Myself, Dr. Priyanka Mandraha. My co-authors, Dr. Professor Pankaj Chaudhary sir, Dr. Anamika ma'am, and Professor Head Dr. Shashi Jain ma'am. My topic of presentation is evaluation of RNFL and GCL thickness in optic neuritis using OCT. No financial interest for this presentation. Optic neuritis is an acute inflammatory disorder of the optic nerve. The disease is characterized by unilateral or bilateral sudden loss of vision, presence of RAPD, and often accompanied by periocular pain. The OCT is a non-invasive ocular imaging technique that uses low coherence interferometry to generate in vivo high resolution within 10 micron cross-sectional images of RNFL by measuring the backscatter of infrared lights. The RNFL measurement can be an objective measurement of the nerve swelling or nerve atrophy by analyzing the ganglion cell complex. The OCT can help to detect the early axonal damage and may predict the visual outcome. Multiple studies and clinical observations support the importance of OCT in the diagnosis, treatment, and follow-up of optic neuropathy. It's an observational cross-sectional study carried out in the Department of Ophthalmology, Shamshah Medical College, Rewa, during a period of 1 year. Case selection was done on the basis of optic disappearance and the presence of RAPD. Patients were diagnosed as optic neuritis unilateral. Healthy controls of similar age-matched group were taken. Inclusion criteria was patients with the optic neuritis age group between 18 to 65 years, those who were willing to participate in the study. Exclusion criteria, patients with any mediopacity, age less than 18 years, more than 65 years, and patients with the AION, CRVO, pseudopapilledema, retinitis pigmentosa, and myopia were excluded. General and systemic evaluation done for association with any systemic disorder, especially with MS. Ophthalmic evaluation was done under visual acuity, ocular movements, pupillary assessment, slit lamp examination, fundus evaluation. All subjects' eyes were scanned with SD-OCT. The parameter for this study recorded were average RNFL thickness and ganglion cell assessment done under average GCL plus IPL thickness. Here is the results. The female dominance was seen in optic neuritis. The mean age of presentation was 38 years. The mean value of average RNFL thickness in optic neuritis 25 eyes and the control eyes were 226 micron and 91 micron respectively. The average GCL thickness mean value in optic neuritis and the control eyes were 64 micron and 82 micron respectively. Statistical analysis was done by unpaired t-test. Here is the OCT scan showing the RNFL thickness is high in a raised in a RNFL thickness in right eye, and the macular scan of the same patient showing the GCL thinning in the right eye. The average RNFL thickness 226 micron was raised in the acute cases of optic neuritis at presentation. Significantly in our study, Sanin et al. Observed in their study the mean age of RNFL thickness was 125 micron in normal population. Novel and et al. Described the raised RNFL thickness 146 micron in acute cases of optic neuritis. Garrison et al. Revealed acute episode of the optic neuritis results in the increased RNFL thickness 195 micron. Henderson et al. Observed the raised RNFL thickness in acute optic neuritis and the thinning of RNFL 88 micron with the long duration. The average GCL and IPL thickness was reduced 64 micron in acute optic neuritis cases at presentation significantly in our study. Jain and al. Studied the average GCL and IPL thickness in the normal population was 82 micron. A study done by Garrison et al. Showed that the ganglion cell complex may represent an especially useful parameter for monitoring ganglion cell loss 64 micron in acute optic neuritis. Walton and et al. Reported that ganglion cell complex thickness was reduced 79 micron in optic neuritis associated with MS. Here, the study concludes that by quantification of RNFL and GCL thickness, OCT provides an indirect measure of axonal and neuronal loss in anterior visual pathways. Subclinical axonal loss in the patients with a normal visual acuity can be also detected. As the ganglion cell complex loss is a hallmark of optic neuropathy, early detection and prognosis in optic neuritis patients should be monitored. Thank you.
Thank you.
Thank you so much.
Thank you.
Is Dr. Abhishek here?
Good evening, everyone. So, my presentation topic is linezolid-induced optic neuropathy in extensively drug-resistant tuberculosis, a prospective analysis of 30 patients presenting to a tertiary eye care hospital in India. So, as we know, tuberculosis is an endemic disease in India, and its prevalence is around 5 per 1,000 population. So, some patients are resistant to the first-line ATT drugs, and those patients are then termed as multi-drug MDR-TB. But some patients, they are resistant to the MDR-TB drug regimen also, and then they are termed as extensively drug-resistant TB. So extensively drug-resistant TB are those who are resistant to isoniazid, rifampicin, and any fluoroquinolone, plus any one of the injectable and ATT drugs, that is either amikacin, kanamycin, or capreamycin. And since we have a large burden of TB in India, so extensively drug-resistant TB cases are also increasing, and its prevalence is around 2 per 1,000 population. So according to World Health Organization, they have devised a XDR-TB regimen, and linezolid is a core drug of that regimen. So among the ATT drugs, ethambutol is known to cause neuropathy, toxic optic neuropathy. But a patient presented to us in the IOPD, and he was neither on ethambutol nor any other conventional ATT drugs. So on review of his records, we found out that he was a XDR-TB patient, and he was on XDR-TB regimen, and his regimen was of linezolid, kanamycin, fluoroquinolones, cycloserine, ethionomide. So we did not know what was causing that vision loss. So on literature search, we found that linezolid also causes toxic optic neuropathy, and thus we devised a study with aim of recording the clinical characteristics of patient presenting to us with linezolid-induced optic neuropathy in extensively drug-resistant TB. So this was a prospective cohort study, and all patients of XDR-TB who presented with linezolid-induced optic neuropathy were included in our study. The study period was of 1 year, from June 2018 to June 2019. So we recorded the age, gender, duration, and doses of linezolid, the presenting visual acuity, the color vision on Ishihara chart, anterior segment fundus examination was done, pupillary reactions was noted, intraocular pressure, and the investigation like VEP, Humphrey visual field, and OCT RNFL was carried out. The inclusion criteria was optic neuropathy secondary to linezolid use in XDR-TB. The exclusion criteria were patients who were on concomitant both ethambutol and linezolid, uncontrolled diabetes and hypertension, advanced glaucomatous disease, macular degeneration patients, those who were congenital color blindness, or had history of ocular trauma. So the patients were evaluated on day 0. They were called again at 1 and 2nd month. Fisher exact test was applied to calculate the relative risk of vision loss with linezolid use. So over a period of 1 year, we got 30 patients who presented to us with linezolid-induced toxic optic neuropathy. Mean age at presentation was around 31 years. 20 were male, 10 females. The average duration of linezolid use was around 7 months, and dosage was 600 mg OD. All patients were on XDR-TB regimen. The visual acuity, it ranged from 6 by 18 to counting finger. Color vision was impaired in all patients. The optic disc findings were very minimal or subclinical. It was either normal or it was mildly hyperemic and mild swelling. And in 8 patients, it was totally pale. VP was depressed in 22 patients and totally flat in 8 patients. On Humphrey visual field, centrocecal scotoma was noted in 36% of patients and non-specific field defects in 36% of subjects. 28% of patients could not go visual field testing because of severe vision loss. OCT RNFL average thickness was either increased or it was high normal in around 70% of patients. In 27% it was reduced. So once the diagnosis was confirmed, they were advised to discontinue the drug, and after 1 month, around 60 patients, they regained near normal vision. Their color vision improved, the VP returned back to normal, and Humphrey visual field also improved in thickness. Humphrey visual field, there was a disappearance of visual field defects, and OCT RNFL improved in thickness. By the second month, 4 more patients regained vision. So a Fisher exact test was done to know the relative risk of vision loss, and it was around 4.7 times. The patients who were on continuous linezolid for more than 5 months, they had at least around 4.7 times risk of vision loss. So some of my case which I will show. So this patient who presented with 6/18 and 6/24 vision, his discs were mildly, it was near normal with mild swelling. So on visual field, did a visual field. So there were centrocecal scotoma in both eyes. OCT RNFL thickness was higher in both eyes. The VP was subnormal amplitude was noted. So he was advised to discontinue the linezolid and to take alternative treatment. So this is the pre-visual field and post-discontinuation. So we can see the disappearance of the visual field defects in both right and left eye. This is the pre-drug use and post-drug use. So this is disappearance of visual field. The OCT also is regaining normal thickness. This was higher and here it is coming back to normal. So VP also, it regained its waveform. So this was a optimal subnormal amplitude VP, and here we can see now appreciable waveforms are seen post 1 month of discontinuation. Similarly, this is the second case where there is mild disc signs, only minimal swelling, and here we can.
Actually, you exceeded your time. You can continue. No problem.
So here also we can see here he had almost a near total flat VP on presentation, and after 1 month of discontinuation there was regain of the normal amplitude and waveform of the VP. And this is since his vision was 660, so we could not do the visual field on the first visit. So after discontinuation of the drug, we can see that he has performed a good visual field test. Same with the OCT RNFL thickness, it was increased, and after 1 month it has come back to normal. So discussion. So linezolid, it is an oxazolidine-dione antibiotic, and it is a core regimen of the XDR-TB. It binds to the 23S ribosomal RNA of the 50S subunit, and thus it inhibits bacterial protein synthesis. So with the same mechanism, it damages the papillomacular bundle, and thus it causes toxic optic neuropathy. So overall, we went to the TB department, and here we found that 330 patients were kept on XDR-TB regimen, and out of them, 30 patients presented to us with toxic optic neuropathy. So prevalence was around 9% in our study.
You might just have to conclude. You're way off time.
Yes, sir. So conclusion, I will say. So prevalence of linezolid-induced toxic optic neuropathy in XDR-TB was around 9% in our study, and it was seen after extended use of around 4 to 6 months. And the main presentation was retrobulbar optic neuritis, and all patients presented with depressed VEP had field defects, either centrocecal scotoma or non-visual unspecified field defects on visual fields, and had increased RNFL thickness. So, and we also saw that earlier the patient presented, better were the chances of visual recovery, and it was the visual recovery was complete after prompt discontinuation in around 1 to 2 months. But some patients who present beyond 2 to 4 months of vision loss, and then they had very poor visual prognosis. So toxicity, it appears to be correlated to the duration of treatment rather than to the cumulative dose. So our recommendation is that any patients who are on XDR-TB regimen, they should undergo a comprehensive ophthalmic evaluation of vision assessment, color vision, pupillary testing, VP, fields, and OCT RNFL after 2 months of initiating the linezolid, and then subsequent examination should be done every 2 months. These are my references. So thank you.
Yeah, nice thought. But how did you diagnose that this optic neuropathy is because of linezolid? And
sir, actually we are in a tertiary care hospital, and ATT drug is freely available there. So our pulmo department, day in day out, they are very busy. TB patients are coming there. So when the first patient came to us, actually he came to us in Feb, and his boards was in March. So mother was very anxious that suddenly his vision is, so we saw his drug, so it was linezolid, ethionamide, kanamycin, capreomycin, so it was neither ethambutol, which I thought that it might be because of that. So then we again did a literature, so we consulted the HOD of the TB department, and he told linezolid causes it. Use it.
No,
Okay, was it differentials?
no, that's known that yeah, linezolid would cause optic neuropathy, but in your series of all these patients, why would you say that this optic neuropathy was because of linezolid and nothing else?
Because
How
they
did
were
you-
so my patients, their age group also, they were relatively younger age group. The average age of presentation is around 30 years. So either they were young or middle-aged patients. So we did the common tests to rule out like optic neuritis. We cannot do MRI in every patient, but XDR TB regimen was there and linezolid was there. So our first DD was linezolid-induced optic neuropathy. Then we ruled out diabetes, hypertension to rule out non-ischemic optic neuropathy. Then we elicited drug abuse history like tobacco, alcohol to rule out toxic optic nerve secondary to drug abuse. So these things only. MRI we could not do in every patient because sometimes TB also causes optic neuritis, but that is very rare. But since it is a government medical college, so in hardly 5 patients only we did MRI to rule out optic neuritis secondary to. And since it was bilateral, so bilateral optic neuritis is that is something systemic is happening rather than any infective process. So this.
Any other systemic impairment wherein you find that these drug toxicities are more?
Yes, so linezolid, it is used in nosocomial pneumonia and skin infections. So actually I have not seen, but I have seen case reports where linezolid was given to a neonatal for neonatal pneumonia, and patient developed retinal complications because of that. But I have not seen, I have seen it.
So generally in patients with renal impairment, the toxicities are?
Yeah, renal impairment, it is excreted by kidney, majority of drug is excreted. But our patient had normal renal, TB department was taking off those kidney and liver parameters because they are either nephrotoxic or hepatotoxic, the TB drug regimen.
All right, thank you.
Thank you, sir.
Thanks so much. So we have, in fact, a semi-final. So Dr. Prachi would prepare the result, and we have Dr. Hirika Kusalia. Right. So we would have a winner of this session compete with you, and then the scientific committee would announce the result. All right. So just give us 3-4 minutes. She will prepare the result. Lovely presentation, everyone. And there were a lot of new thoughts, there were a lot of new ideas, and brilliantly done. Few things, I mean, this is apart from conveying what you want to convey, your new ideas and all, this is also a competition, so make sure that the time is adhered to, because that's one of the important criteria for judging. But yeah, it was really good.
Okay. So thank you for the lovely presentations. The